Our next speaker will be Dr. Koussayer. He is a consultant vascular surgeon in King Faisal Specialist Hospital, Riyadh.
First, I'd like to thank the scientific committee for inviting me for this nice meetings. I'm going to talk about CHIPS really and hybrid repair of the thoracoabdominal aortic aneurysms. As all of us, we know the classification of thoracoabdominal aortic aneurysm from type 1 to type 5 depend on the extension of the pathology. Open repair being a standard treatment for thoracoabdominal aortic aneurysm, but the problem required a long thoracoabdominal incisions. It required a partial cardiopulmonary bypass machines. It has a significant morbidity and mortality, and most are related to the ischemic-induced injury to the viscera, kidney, and spinal cords. Most common complications with the open repair are paraplegia, false aneurysm, redissections, paralysis, stroke, renal failure, and infections. The reason why the endovascular becomes a new frontier. The advantage of the endovascular, it's minimal invasive procedures, reduce blood loss up to 60%, reduce the stress response, no aortic cross clamping is necessary, 30-day survival advantage, early ambulation, and shorter hospital stay up to 50%. To place a stent graft, as all of us we know, we need at least 2 centimeter proximal and distal as a landing zone for TEVAR. The problem is when the pathology extends and involving the visceral artery and the renal arteries, this leading to thoracoabdominal aortic aneurysms. What the solution for endovascular repair? We have a branch and fixated TEVAR, and the speakers before they talk about this in details, Dr. Adams. And with the second alternative is CHIPS, which would mean chimney, periscope, or sandwich technique. The previous EVAR, thoracoabdominal aortic aneurysm, and if you have an aortic arch aneurysms. You can use a single chimney, or sometimes we can do a double chimney like this case, where we have a previous EVAR, which migrate, and now it's very close to the renal artery, so we have to put 2 chimneys in the renal artery and extend the graft all the way above the renal arteries. When you come to the chimney, there's some considerations. It's very important to measure the distance between the renal artery and SMA. If it's more than 2 centimeters, then we just need to do a chimney for the renal arteries, 1 or 2. If the distance between renal arteries and the SMA less than 2 centimeters, then we have to put a chimney in the SMA also. And the same for SMA and celiac artery. If it's less than 2 centimeters, then we have to go and also do a chimney for the celiac artery also. If we talk about 3 or 4 chimney, then it's better to switch to the sandwich technique, because chimney is good for 1 or 2 branch, but when you go 3 or 4, you get a better result by using sandwich technique. Periscope technique is the same as sandwich. The only thing we put the branch cover stent in a reverse position, so we get a retrograde flow from below. What the limitation of this technique? The sealing is a problem, especially when you increase the number of the chimneys. The more chimneys, the more chance of leaking from the gutters. The second thing is narrowing at the area where you put the chimneys, especially if you have a small aorta which is less than 16 millimeters. Especially if you put a periscope where is a retrograde, where is the flow depend on retrograde flow from the lower part of the EVAR. So it's very important to look at the sizing and be sure that you have the size of the aorta is adequate to put the chimney or the periscope or the sandwich. What the solution? We have couple bailout. If you have a narrow aorta, plan A to do a hybrid procedure. That means you can do hybrid for like 2 branch and put a chimney for the other 2 branch, or vice versa. Or the other plan is instead of put 3 chimney, you do a scallop for the SMA and you put 2 chimney for the renal arteries. It's very overlapping is very important when it comes to the chimney. You need at least 2 centimeters overlap between the aorta and the EVAR. Sandwich technique is the same as a chimney. The only thing is different. The chimneys will be trapped between 2 cover stent. So put a cover stent, and then the branch between the chimneys will be between the cover stent. As you can see here, this is the first one, this is the second, and this is branched or the viaband. The technique first, we deploy the proximal one, then we put our chimneys in the visceral artery. Then we do the distal EVAR, and at the end we place the bridge one. We do all this one before we deploy the branch stent, cover stent, and even we balloon inside the EVAR or TVAR, and at the end we deployed the branch cover stent, which is a Viaban or V12. This is a couple of the cases where you see the branch trapped between two stent graft. This is for 3. The problem with sandwich technique is a type 1A endoleak, where you see endoleak from the gutters, and the solution for that use coils or onyx. Like this case, we can see the type 1 endoleak was treated successfully with the coils. It's very important to come to the sizing. Usually when you do EVAR or TVAR, we go up to 15% oversize. When you come to the chimney, 15% is not enough. You get type 1 endoleak. So you have to go to 30% oversize. If you go to 40%, then it's too much oversize. You get to the infolding. The other way is to measure that is to use this formula. Use maximum aortic diameters plus the diameter of the chimneys you put there and divide by 2, and this will be your size of the TVAR. What about the hybrid repair? I'm going to speak about a couple cases we do at King Faisal's. We refer the case from other centers because I had high risk for open repair and deny surgery from other centers. They should be able to tolerate at least laparotomy and cross-clamping and end-stage ischemia for a short period. How morbid is the debranching procedure? It's a morbid procedure. It's not minimally invasive at all for both for the surgeon and for the physicians and for the patients. Usually we do a combined procedure. We don't do a staged procedures. So what happens, we do debranching first, the visceral artery, renal artery, and then we follow with a TVAR. It requires a thorough analysis and decision-making process, especially when it comes to renal revascularizations, because you need end-to-end anastomosis, need a lot of technical skills. The same for the celiac, because you have to pass your graft behind the pancreas. Luckily now, Gorzi came up with a hybrid vascular graft, which is very nice. It makes your anastomosis much easier, especially when it comes to the renal or celiac artery. This is a graft which is, part of it is like Viaban, and the other part is regular graft. We can use it for all the branches, and we have 2 techniques. Either we do standard technique where you make a small incision in the artery, you put your the collapsed part, and then you deploy it by pulling the thread like Viaban, or you use over-the-wire technique. And this really makes the procedure much easier. Show a couple cases at King Faisal. This is patient 56 years old male who referred us with a previous TVAR in 2008. When he came to us, he has a large thoracoabdominal aortic aneurysms, and he came with a lac claudication and became cachectic because he has an SMA occlusion and celiac stenosis. Also, he has a single renal artery. The other one is atrophic. And he has also infrarenal aortic aneurysm measuring about 6.6 centimeters. This is the CT. You can see the large aneurysms here. The type 4 celiac stenosis, SMA occlusions, and also he has an iliac occlusion also. Sorry, celiac occlusion, SMA stenosis. And also what makes things more complicated, he has a complete iliac occlusion here. So this is a 3D reconstruction. This is the previous stent. And this is what we have now: celiac occlusion, SMA stenosis, single renal artery, and occluded iliac arteries. What we do, branch of straight stent graft, chips, hybrid or open repair. We're thinking about the best options, and then he make it easier for us. He came with the ruptures, so we have to rush him to the OR. We put a spinal drain. Then we open him up. We found that the rupture, luckily it was a rupture only in the thoracic part. There was no free blood in the abdomen. So we had the time to do an aorto biofem. We took the kidney, because as a single kidney, you have a good active transplant team, so we took the kidney to the side to do auto transplant at the end of the procedures. And so we harvested the left kidney. Infra-aortic clamp was performed. We did aorto biofem. And then we did a bypass only to the SMA because the celiac was occluded. Then we deployed 2 cover stent overlapping the thoracic aneurysm all the way inside our aorto biofem. And at the end, we put the kidney back in the right pelvic area. This is how it looks at the end. This is our aorto biofem. This is bypass to the celiac. SMA is already occluded. This is our cover stent. Then we do auto transplant of the kidney to the right limb of the aorto biofem. Postoperative, no paraplegia. Renal profile were okay. Abdominal angina resolved. He was able to eat. And this is post-op CT. We can see a good perfusion to the transplant kidney and patent bypass with complete exclusion of the thoracoabdominal aortic aneurysm and no endoleak. Another patient, 52 years old, he came to us also with allergic thoracoabdominal aortic aneurysms, severe leg pain and back pain, and has severe COPD. He has a previous stroke with a mild hemiparesis. The problem with this patient, the CT showed he has complete occlusion of the infrarenal aorta. The infrarenal aneurysms was completely thrombosed. He has single renal artery, atrophic left kidney, and also we have a problem here with an axis. This is a CT. You can see here complete thrombosis of the infrarenal aorta. This 3D reconstruction here. You can see complete occlusion of the infrarenal aorta. So should we do branch fenestrated? There's a problem with the axis. The same for chips. So we decided to go with a hybrid or open repair. He has severe COPD, so we decided to go with a hybrid repair. The same, we replace a spinal drain. We did an aorta biofilm on the infrarenal aorta without climbing the aorta because the infrarenal aorta is thrombosed. Then we put a second bifurcated graft in reverse position to debranch the SMA and right renal and celiac artery. We did open thrombectomy through the main graft to get access to the suprarenal aorta to deploy the TVAR. Then we deployed two TVAR, and the end angiogram revealed good exclusion of the aneurysm without any endoleak. This is how it looks at the end. Aorta biofilm, debranch, and then our cover stent. And this is during the surgery, where you can see our this is our aorta biofilm. This is a debranch. This is going to the right renal. This is celiac. And this at the end, we deployed the TVAR. This is the intraoperative angiogram, complete exclusion of the aneurysms, good flow to the SMA and celiac, and to the right renal artery. Again, postoperative patient function was deteriorated only for a couple of days and went normalized. No stroke and no paraplegia. The last case is 75 years old, also came with a type 5 thoracoabdominal aortic aneurysm. He already has a kidney transplant, so we don't have to worry about his kidney. This is the CT. So what happened, we debranched his celiac and SMA. Then we put a conduit, and through that we put our cover stent to fix the thoracic part of the TVAR. This is the celiac artery. This is our debranching graft. This is anastomose to the celiac and SMA. And then we put a conduit, and then we deployed our TVAR. This is intraoperative angiogram, complete exclusion and no endoleak, and this 3D reconstructions. Complication of the hybrid, still a paraplegia is a problem, but it's much less than the open repair. It's about like 3 to 5%. Renal failure, respiratory failure, and re-intervention. So hybrid procedure is a more tolerable procedure with less morbidity, afford high-risk patient alternative to open repair. Complication and mortality are lower, and neuro event is much significantly less than open repair. So as conclusion, we think that the rapid improvement in the endograft technology over the last 10 years has expanded the indication for endorenal grafting. Hybrid repair and CHIPS technology are various options available with low risk and off-the-shelf hardware. Especially if you have an emergency, the choice of preferred technique depends on experience, availability, and urgency. The fit young patient with unfavorable anatomy is still controversial. Thank you very much.